So, good afternoon again. We are going to talk about assessment and management of brachial plexus injuries. The first thing I would like to emphasize is that in recent years, we're observing a rising wave of enthusiasm towards the treatment of brachial plexus injuries because there is a remarkable increasing rate of these injuries, especially in Asia, and unfortunately due to ongoing warfare in the Arab world. Now, regardless of the epidemiological impact, we have to consider that brachial plexus injuries usually affect young individuals, mainly males, between 15 and 35 years of age. Now, some people may actually question the need of performing brachial plexus surgery in low-income or middle-income countries, but I would like to consider that if you have somebody that is young and develops a severe disability, these actually result in an additional burden on the shoulder of the family. So the main thing with brachial plexus injuries for those that are not very much into this kind of surgery is to distinguish between patients that present the possibility to spontaneously recover and those that have no such potential and the only hope they have to restore some functioning that the nervated limb is just surgery, which is actually the majority of them. So what do we do when we assess a patient with a brachial plexus injury? The first thing is that we have to try to identify exactly the kind of damage and the extension of damage on the brachial plexus, trying to understand whether this lesion is susceptible for spontaneous recovery or we have to consider the patient a candidate for surgical repair, decide the timing for surgery and the repair strategy that we are going to apply. Now, there might be some difficulty in assessing a patient with brachial plexus injury immediately after the traumatic event because most of these patients are actually multi-trauma victims. They might be comatose. First of all, about 20% of patients, usually the patients that present an infraclavicular injury, might have an associated vascular injury. Therefore, if you are going to see signs related to a possible vascular injury in the upper limb, or for instance, an hypovolemic shock, you have to consider that this might be the case. Now, usually patients that present a vascular injury and brachial plexus injury are going to be given indication for urgent arteriography and treated by the vascular surgeon. It's unlikely that you have a brachial plexus surgery in the same location, and therefore the repair of the brachial plexus injury is going to be delayed. And usually what happens is that in this case, you are actually going to have two different kinds of damage. The damage that was consequent to the traumatic event and the damage that might occur as a iatrogenic consequence because of the vascular surgery. Not that I want to blame the vascular surgeons, it's just that it might be very difficult sometimes and they might accidentally damage the brachial plexus more. 40% of patients usually present associated bone injuries, fractures or dislocations. There might be the whole spectrum of fractures of the upper limb, but there are some fractures that you should actually pay attention to when you see them because these might be related to a brachial plexus injury. So the first thing is that if you examine a patient whose cervical spine presents several fractures of transverse processes or lamina, consider it's likely this patient might have root avulsions and a brachial plexus injury. And there might be a high suspicion of a brachial plexus injury also for clavicular fractures, which are definitely the most frequently bone injury in association with brachial plexus injuries. A patient may present with the Horner sign. The Horner sign may be immediately after the traumatic event or after 48 hours after the traumatic event. Now, of course, Horner sign poses a problem of differential diagnosis with the anisocoria related to head injuries. Of course, as neurosurgeons, we do not have a problem in assessing the scans and trying to understand whether the asymmetry of the pupils correlates with the CT scan. But consider that in Horner sign, the mediatric pupil is well reacting to light when it is associated to brachial plexus injury. An X-ray showing this kind of image should prompt to consider a palsy of the phrenic nerve and the possibility of a brachial plexus injury. And 2% of patients might present an incomplete Brown-Séquard syndrome that is usually related to multiple avulsions and consequently a damage along the cervical spinal cord. When you assess a patient weeks or months after the injury, things are certainly going to be easier. But the main thing is that we have to decide who is going for surgery or who can spontaneously recover. Now, the core of the assessment in these cases is to differentiate between pre- and post-ganglionic injuries. Now, pre-ganglionic injuries means root avulsions, means that the root has lost the continuity with the spinal cord. We might have complete avulsions or we might have partial avulsions, and these are actually very tricky to be diagnosed clinically and radiologically. Now, the thing that we have to keep in mind, if you do have evidence or if you raise suspicion of avulsive injuries, you have to exclude the possibility of spontaneous recovery, and this patient is a candidate for surgery. There's no possibility for spontaneous recovery. Waiting is just a waste of time. We jeopardize possibilities of favorable outcome. 70% of brachial plexus patients will present root avulsions, which are usually more frequent at the lower roots, C8 and T1. And in 90% of cases are associated with the formation of mushroom-shaped pockets, which are called pseudomeningocele, which are the consequence of a tear of the dura surrounding the nerve root that is going to be filled by CSF through an arachnoidal bulging. Now, it's important to consider that usually pseudomeningocele are not evident immediately after the trauma, but they need up to 3-4 weeks before they are completed. And this is the image of pseudomeningocele at myelography, 3-dimensional myelography, and surgical exploration. Now, can we detect avulsions when we assess the patients, or we just have to rely on imaging? Yes, there are clinical signs that are the ones listed here. Some of them, we already mentioned them before. So, Horner sign. It's important to consider that if you are going to assess the patient weeks or months afterwards, you can actually have the disappearance of the Horner sign. So it's always important that you check the official medical records and see if an Horner sign was mentioned there. Sometimes it's not that easy to assess an Horner sign, especially in patients that present dark eyes. Horner sign is related to avulsions of C8 and T1 as an indirect evidence because it's actually consequent of an injury to the stellate ganglion. And it's, of course, a bad prognostic indicator. Another sign of avulsion is a palsy of the rhomboid muscles. This is related to functional impairment of the dorsoscapular nerve, and because it's as a proximal branching off from C5, again, it's an indirect sign of avulsions. But it's not so easy to check them on patients, especially if they have bulky trapezius, so you better rely on EMG for that. Winging scapula is very easy to be assessed in patients. It's clearly evident. Now, there is something we have to consider. The long thoracic nerve, which is the nerve innervating the serratus anterior, has 3 roots, C5, C6, and C7. If just one of these is still in continuity with the spinal cord, you have some residual function in the serratus anterior. Therefore, if you see a patient with a winging scapula, this means you have a complete denervation of the serratus anterior and a damage on C5, C6, and C7, multiple avulsions. Phrenic nerve palsy, we already mentioned before. This is usually well tolerated by the patient and should be revealed by a chest X-ray performed during inspiration. We also manage about the incomplete Brown-Séquard syndrome. Is usually a reversible deficit, but again, bad prognostic indicator, sign of multiple avulsions. And 3% of patients may present an external meningocele. Now, something that we really have to pay attention to when we assess a patient is a very typical form of pain that is called deafferentation pain. Patients with brachial plexus injuries do present pain related to osteoarticular pain, neuropathic pain, but deafferentation pain is very specific. It's just correlated with avulsions, and you find it regularly in these patients. We do not really understand what causes this particular kind of pain. We say that it's the firing of the neurons after the avulsions has occurred, but there might be also a central mechanism that involves the pain matrix and puppet circuit. But what is important to note is that the clinical presentation is a very typical one. The patient complains about persisting continuous pain, usually described as burning or the sensation of having the hand crushed in a vice. And then they have paroxystic, painful electric fits, mostly on the end. And these patients sometimes can have several fits per hour, and really their life becomes an ordeal. Now, once we have decided that the patient may or may not have avulsions, we are supposed to try to identify the kind of injury pattern. We distinguish between supraclavicular and infraclavicular injuries. Upper plexus palsy are related to a damage on C5, C6, and possibly even C7. And usually we have a loss of proximal function, loss of shoulder movement, biceps, and if also C5, C7 is impaired, then we also have a loss of triceps and distal extensors. Upper brachial plexus palsy may also present with a remarkable shoulder muscle atrophy and subluxation of the humeral head. Lower plexus palsies are fortunately very uncommon. Only 3% of patients, 98% of them present Horner sign related to avulsions of the lower roots. And you have a good proximal function, but you have a complete loss of the dexterity of the fine movements of the hand. Total plexus palsy are the ones that we see in large percentage. More than 50% of patients will present a damage all over the plexus. And this is usually a combination of preganglionic and postganglionic injuries. Infraclavicular plexus palsy are 25% of them, very often associated with vascular injuries, as I mentioned before, and the clinical presentation may be a little bit tricky because it depends on the cords that have been involved in the damage. Now, how do we assess patients besides clinical evaluation? We have electrodiagnostic tests and neuroradiology. Now, every time I say that, I know that I'm going to raise some, controversial reactions in the floor, but the truth is that electrodiagnostic tests are not that useful because they highly depend on the experience of the operator. And I can give you evidence of patients that came with 3 different EMG done in different departments, each showing a different kind of damage. So neuroradiological investigations are the real core of diagnostic assessment. Nowadays, we should give up MyeloCT. It's not the first choice investigation anymore. It's an invasive technique, and it's actually been overcome by 3-dimensional MRI, at least whenever you can afford it. It's the first choice investigation. And usually the best thing would be to rely on a protocol that includes MRI, myelography, neurography, and it's still experimental, but DTI also seems to give good evidence of avulsions. The important thing is to consider that this modality can also offer you not only information about the proximal situation of the plexus, but also see whether there is a neuroma or a disruption of the cords. Timing for surgery. I mentioned before, if you have clinical suspicions confirmed by radiological assessment that there are avulsions, you have to go for surgery, and you have to go for surgery as soon as possible. If you have a traction injury without signs of avulsions, if it's a pure postganglionic injury, you may have a wait-and-see approach. But if you do not see clinical sign of spontaneous recovery, or you do not detect them at electrodiagnostic test, again, you have to go for surgery. Thanks for your attention.